Okay. I guess we can get started. Welcome, everyone. Hello, and welcome to UVA Medical Center Hour. I'm Irène Mathieu, Assistant Co-Director of the Program in Health Humanities at UVA Center for Health Humanities and Ethics. We're delighted to see you joining us today virtually and in person to learn from Dr. Celeste Lipkes and celebrate her new book of poems, Radium Girl. Just a brief word about the structure for today's event. Firstly, and perhaps most importantly, if you're here in person, please help yourself to lunch catered from Feast. Note that all packaging materials are compostable, and there's a compost bin in the corridor just outside this room. All of our speakers have completed conflict of interest statements and have no disclosures. Please also note that continuing education credit can be claimed for today's event. We invite you to follow the steps at the bottom of the handout posted in the chat to claim your CE. When the time comes for the question and answer portion of the event, please send your questions through the Q&A option on Zoom, which I will be monitoring. Now I'll introduce today's speaker. Celeste Lipkes, MD, MFA, is a staff inpatient consult psychiatrist at the Charles George VA Hospital in Asheville, North Carolina. Her debut poetry collection, Radium Girl, was just published this month by the University of Wisconsin Poetry Series. Prior to attending Virginia Commonwealth University for medical school, she received her MFA in poetry at the University of Virginia. She's taught poetry workshops at UVA, Kenyon Review Young Writers Workshop, and for patients in various medical settings. She is currently at work on a series of lyric essays exploring her experiences as a patient and a physician. For additional information, please visit her website, www.celestelipkes.com. Radium Girl is an exquisite book with phrases like the IV bag shrinks moon-like over my head and the nurse who moves her hands like silk sinking into a coy dappled pool. Radium Girl traverses the short distance between imagery and imagination. Lipkes works the language like a magician. Under her watchful pen, she guides the reader on dual journeys through medical training and through what Susan Sontag called the kingdom of the sick. These voyages are radiant, piercing, tender, and always guided by this poet's enchanting and enchanted voice. I so enjoyed reading Radium Girl, and without further ado, I'll now turn the program over to Dr. Celeste Lipkes.
That was such a generous introduction. Thank you so much. I'm going to do my best with a limited knowledge of technology to pull up my slides for you all. Can everybody see these okay? Okay, lovely. Thank you all so much for having me. It is such an honor to be here. I came to UVA for my MFA and often came to Med Center Hour kind of peeking in behind the curtain of medicine, wondering if I would ever kind of be in the crowd. And it's such an honor to be on the other side of the podium talking to you all today. This talk is, I want to leave some room for conversation, so I'll try to read and talk for like 30 to 35 minutes or so. I titled this talk, Two Ends of the Stethoscope, Writing as a Patient Physician. My first book of poems, Radium Girl, just came out this month. And I wanted to do kind of a different spin on a reading today, read some poems, but then also talk a little bit about my experience more explicitly as a medical student with history of illness and the ways in which that complicated my journey through medicine, and then how to best support those students in an academic setting. So I love a learning goal. I think it's great to kind of know where we're going when you're listening to a talk. So again, we're going to kind of walk through a couple different sections of the book, thinking first about my experience in childhood and adolescent illness, and then more about the medical journey itself, and then my little wish list for medical schools moving forward. So first, in thinking about my experience with illness, which is really highlighted in this book, I wanted to pull up first the table of contents for the book, because it's kind of an odd book. It has one long poem about magic running through it, and that's in 4 different sections. And so we're going to start with the first 2 sections because those are the sections that are really focused on my illness journey. And the book is sort of tricky. It focuses on different magic tricks. And the reason I did that will become clear as we talk more, but I think it's often hard to address some of these topics head on, and to have a frame of metaphor can be really useful. And so I kind of latched onto this idea of different magic tricks. So the first section is going to kind of ruminate on the magic trick of pulling a rabbit from a hat. And the second section focuses more on making a dove disappear. And again, these are both kind of highlighting my illness journey throughout the book. I'm going to read a few sections from the Rabbit and the Dove poems. As you can see from the table of contents, they are kind of braided throughout the book, but I will read them just in order, and I'll try to give a little bit of space between the sections so it's clear when there's a break, because I did have to put 2 columns, as you can see here on some of the slides, just to fit everything in. So first, from Rabbit. Rabbit. Some hats are more likely to contain rabbits. I flipped bowlers, put my ear to a turban's origami, fingered the linings of Sunday bonnets, and came up empty. I regret to inform you, said the silence, that not all things are possible. A cage for every bunny, a hook for every hat, a pillow for every head that dreams of finding something hidden. So often we miss it. Once I saw a man holding a Russian doll, unaware of all the women in his palm. Even God, bringing light into the world, was pleasantly surprised to find inside the white a split of yellow, red, blue, green. When the doctor says, we found something, I don't say, no shit, or, oh, thank God I've been looking for that sweater everywhere, or, I have been discovering things for months. An ember in my stomach, rubies of blood clots studding the toilet bowl, the meaning of the word collapse. Instead, I nod and the silence unfolds itself like a paper crane until the doctor clears his throat and says, I'm sorry. In the schema I have established, the doctor is the magician and I am the rabbit. But I regret to inform you that there are other possibilities. God is also the magician, pulling the disease from the hat of my body. I am the magician even, some nights alone, finding inside the darkness a small, trembling thing I won't acknowledge as my own. This is someone else's rabbit, I say, and the silence nods back. Method 1. Acquire a top hat and a table with a secret rabbit-sized opening. Line a box with shredded newspaper. Place a bunny in the box attached to the bottom of the table. Cover the table with a tablecloth. Practice with the rabbit until she waits calmly to be lifted into the light, until she knows that abracadabra means, here comes the hand. Method 2. Crush charcoal to dust and coat the rabbit until she is the exact degree of dark as the inside of a hat. Deprive her of food and drink for 3 to 4 hours to avoid a mess. Place her in the hat and put the hat on your head before you walk on stage. It is not recommended that you wear the rabbit for an extended period of time. Before the trick is performed, the rabbit must be trained to shut her eyes on cue. Snapping one's fingers is the most popular signal. When you tilt the hat so the audience can verify its emptiness, its distinctive lack of rabbit, use the cue so the wet shine of the rabbit's pupils doesn't give her away. Brush off the charcoal discreetly. Here abracadabra means be clean, and pull her up by the white scruff of her neck. Method 1. Discovery via interrogation. When did it start? Have you been abroad in the past 6 months? Do you own or have you recently come into contact with any exotic animals, an iguana, for example? Have you changed your diet since the symptoms began? Is there a family history of stomach problems? Where does it hurt? Have you recently gone swimming in any freshwater lakes or streams? How much does it hurt quantitatively on a scale from 1 to 10, 1 being normal and 10 being the worst pain you've ever experienced? The questions are asked, but the body is silent. Method 2. Collect the dispensable. Vials of blood, a cup of warm urine, excrement in a screw-topped canister. Examine the mouth, palpate the abdomen, insert your latex finger where no finger has gone before. Prior to being presented to the white-coated, there must be a purification. Allow no food or drink for days, save for jugs of polyethylene glycol mixed with Gatorade. Verify the gut's emptiness, a distinctive pink-ribbed cleanness. Collect tissue, take pictures, leave no trace of entry. Everything the body says will be used against you. Now I'm going to move into a couple of the Dove poems, and then we'll pause and chat a little bit about all the content. Dove. There is a bird that will sing both halves of a duet when its mate dies, but that bird is not a dove. There is a bird from the swamp of my childhood, all dinosaur and plume, but that bird is not a dove. There is a bird that crosses oceans with clouds of its compatriots, but that bird is not a dove. Negate all of birddom in search of the most silent, the most docile, the most willing to forget its form in favor of a handkerchief, a lip match. Animalia cordata vertebrata aves columbiformis columbidae. Say this prayer until the white one appears. My fever is so high, I hallucinate mice circling the IV pole, my dead grandmother dragging a fork through my Jell-O cup. What do people do, I ask the nurse, when they can't stop seeing things? She hands me a stack of paper and teaches me to fold a crane. Columbidae, columbiformis, aves vertebrata, cordata, animalia disappears. I have a chronic autoimmune illness named after the man who discovered it. Imagine if God named everything God. Beryl Bernard Crohn. Crohn's disease is characterized by inflammation of the gastrointestinal tract. I am in the hospital because doctors say I am failing to thrive. I weigh 98 pounds and use the bathroom 17 times a day. My father does not say much, but looks at me with wide eyes when he thinks I am asleep. My mother takes notes in a yellow legal pad and twists her wedding ring around and around. No one asks what makes me happy now, that I can't dance or go to high school or eat fettuccine Alfredo. I watch Whose Line Is It Anyway? And take the hottest shower I can stand with my face pressed against the frosted window. I don't remember asking my mother if I'd ever feel better, but she says I did. Says she went home and pulled the car into the garage, turned off the car, closed the garage door, and cried. When I go to sleep, I feel myself slipping like sand between the twin fists of an hourglass. Only the yellow legal pad knows how many times my medications have been switched. Promethazine, budesonide, mesalamine, azathioprine, prednisone, sulfasalazine, hyoscyamine, dicyclamine, ondansetron, the names of Martian children. When the doctors believe I am wasting away by small enough increments, I am released from the cage of the hospital. The days shuffle into place like cards in a deck. I go to class when I can, take my pills in the bathroom, try to ignore the girls whispering to each other about how I have an eating disorder. A mother of a girl in my dance class approaches my ballet teacher, says she is concerned for my well-being. She spends our class in the lobby, gossiping about the latest diet trends. Fat bitch, my mom says, and we smile and go shopping for jeans that will fit. Did you know that they make size 00? 2 zeros for the extra empty. When a boy in my chemistry class asks if I'm dying, I say yes, and everyone leaves me alone. When teachers pull me aside and ask if I need extensions on my assignments, I say no. When I ask God if I will ever feel normal again, I take the silence to mean maybe. The doctor asks to speak to me alone. He perches on the edge of the bed, smooths the sheets with his gloved hand. There are some things you should no longer do, he says. He hands me a list. No popcorn, no blood donation, no alcohol. 2 stapled pages of negations. He says, I know you are young. I stare at a spot just above his left shoulder. But I need to tell you that while certain forms of sexual intercourse are not recommended for people with your condition, I am 14, I like to read, eat strawberries by the pool, kiss my dog between his golden ears. This is just as uncomfortable for me as it is for you, he says, popping the balloon of silence. I say, okay, I say, thank you, I smile. I fold 2 new cranes with staple slits for eyes. So I know that's a lot of content. I wanted to sort of highlight a couple of things. Again, I'm speaking today from my own personal experience with illness and medical training. I'm not an academic that has studied the subject. I do think that my experiences from talking to other folks are pretty generalizable. In this slide, I wanted to highlight some of the psychological effects of childhood and adolescent illness that I encountered and that I write about in these poems, some of which were highlighted in the sections I read. So definitely an extreme amount of isolation, both from my peers, my family, at school, and with that, a large amount of bodily shame. I think any illness obviously comes with some amount of that, unfortunately, but I think any illness where there's bodily fluids involved, having to go to the bathroom very frequently, particularly as a female adolescent, that was really difficult. Just to highlight a couple more of these, there was, as you noticed in that conversation with the physician, some desexualization or over-sexualization of the adolescent and the illness role. There's a lot of rearrangement of familial roles in these instances, guilt over the sick role, and I'll highlight the concern about lack of productivity was something I really felt, particularly as a student. Like, I'm sick and I'm missing class, so I really have to show that I'm like the best student. And so when my teacher says, do you need an extension on assignment? I say no, and I definitely should have said yes. That's just one example. Obviously, once you're older and you have a job, it kind of bleeds into that as well. But fear in general, but I tried to highlight relapse of symptoms, fear of pain, fear of losing control of bodily functions, particularly with Crohn's disease. I think that that is a pretty good list of some of the themes that come up in these poems that then affected my journey through medicine. So I wanted to move forward in time and look at a couple of sections of the book where I am already in medical training. And so these are going to be the second 2 magic sections of the book. The tricks that these sections focus on is hemicorporectomy, which is cutting a woman in half. And I really loved that metaphor because I felt very much like I was cut in half in medical school. Like, I'm a patient and am I a doctor, and how do I put those things together? And I'm also a writer and a physician, and how do I put those things together? And then escape acts are highlighted in the last section appropriately, because I'm really trying to escape writing this poem that's been going on for so long. So I'll read a couple sections from the cutting woman in half and the escape, and then we'll highlight again some of the experiences I had as a person with history of illness, training in medicine. Hemicorporectomy, noun. 1, a radical surgery in which the body below the waist is amputated, transecting the lumbar spine. 2, King Solomon's prescription for justice. During medical school orientation, I began a trick that takes years to perfect, transfiguring the cape of my hospital gown into a white coat, charming the snowflaked smock to dissolve. I keep ending up with only half of me, doctor. I'm a turncoat with a stethoscope, reciting the Hippocratic Oath. A standardized patient tells us about her pain, and we practice empathic responses. Women like it when you listen, says a surgeon. Nod your head, he says. Say things like, I can only imagine. Scenario 1. The day we bisect the cadaver's face, I am cutting 2 women in 2. The boys flip her onto her back, cursing her weight, 4 inches of slick yellow fat over her torso. We elevate her head with a wooden block, pull a sheet up to her neck, the claws of her hands dangling over the edge of the table. Check for dentures, says the professor. They're impossible to cut through. I run my gloved finger over her gums, the dryness startling me back into my body. Everything that should be wet isn't. Her amber skin, her half-closed eyes, between which One of the boys draws a line with his finger from scalp to clavicle. Here, he says, and lets the saw shriek through her forehead. Scenario 2. The day we bisect the cadaver's face, I stay in bed. We practice on illusions of people, an actor cradling a baby doll. She won't stop crying, Mom says. A cadaver whose only identifiers are 65, female, pulmonary failure, a high-tech male mannequin voiced by a woman. We're short on staff, the facilitator apologizes. In one session, the mannequin will not stop seizing. We scatter to apply oxygen, press our hands to its heaving plastic chest. It's our 4th week in school and we know nothing of medicine. My own heart matches the mechanized throb, panic filling me to the brim. I don't know what I'm doing. I don't know what I'm doing. My stethoscope trembling until the director calls time and tells us our patient is dead. Escape. In the classification of escape performance, the most respected genre is escape or die. The flirting with conclusion never ends. Death by drowning, death by falling, death by suffocation. The goal is escalation. But even Houdini learned his limits the night he couldn't break the handcuffs secret. The London Daily Mirror challenged him to escape from cuffs that took a locksmith 5 years to create. Trapped, Houdini kissed his wife on stage, the silver key slipping between their lips. Nights on call in the ICU, I walk laps past bodies ensnared in tubes, bags of blood like vultures overhead. Every evening, I count the dwindling brass coins of my patient's platelets, while his wife ices cups of ginger ale he will never drink. When his face becomes a mask of itself, she lies down in bed and sings him a hymn. This is the greatest magic trick, escaping the body gracefully. Never underestimate the training required to know when to signal for the key. In the schema I have established, the patient is the magician and illness is the handcuffs. But again, there are other possibilities. I am also the illusionist, leaving behind the cape of my hospital gown. Even poems are a trap to break free from. In this way, you are also a magician. If you find a way out, please let me know. When I was very ill, I spent evenings locked in the bathroom. I had prednisone-induced insomnia, and my eyelids were tangled window blinds I couldn't close. Those nights when wellness felt impossible, I sat on the yellow tile next to the toilet and watched videos of card tricks. A woman from the audience signs the Queen of Spades with a black marker and shuffles it into the deck, only to have the magician pull the card from his wallet. Then he rips the Queen in fours, and he presses the confetti into the woman's hand. You know what happens next, not the part where the Queen reappears untorn in the middle of the deck, but the part where I am finally given infusions of medication and can visit the bathroom rather than taking up inhabitants, drink strawberry milkshakes instead of barium chalk that makes my insides glow. Not when the magician shows the woman the card and points to her signature, but the part where I call my mother to tell her that I have been accepted into medical school and her shouts kaleidoscope down the hallway. Not when the magician says, "Is this your card?" Because she has signed it, it is hers. But the part where my patient waiting to be discharged asks, "Is today the day?" And when she says, "Yes, it is," not the clapping, but the amazement before it. That's the very end of the book that I just read there. So you got a full tour. I really wanted to use this space to think about how these poems are illustrating some of the strengths and challenges that a person like me bring to the medical field. And so I want to highlight a few of these here, starting with what are some of the benefits of recruiting and retaining students who have history of illness, experience, or disability. One thing I found in my clinical time is that I felt like I had a really innate understanding of some of the really difficult to teach patient experiences that took a big psychic and physical burden. One thing that I thought of immediately was the burden of a lack of diagnosis. So the period between the onset of symptoms and a firm or clear diagnosis, as we know, can be days, but most often is months and weeks, sometimes years. And so I remember when I was told I had Crohn's disease, I felt like someone had given me a coin. So I now had like something I could use to like barter in this system. And that's a difficult to teach patient experience. Even if I think you explain that to students, it's not something they can necessarily hold for the remainder of their training. So that's been very helpful. I think I have often had examples with my own care team where the communication has not been clear or consistent, and that's led to a vast excess of anxiety on my end. And so having that experience makes me very motivated to be clear and consistent in my communication with patients and families. And also thinking ahead of, I'm prescribing this medication. How is the patient going to pay for this medication? How are they going to get to the pharmacy? These barriers to care that we constantly encounter, some of them are there and we can't do anything about them. And some of the time, if we think ahead or have some sort of inside knowledge about what the patient might be experiencing in terms of trying to execute the care plan, we can step in earlier and be helpful. I also had the sense that because of my experiences as a patient and taking medications and having numerous tests done, I had a sense of the burden, economic time, side effect burden of all those interventions. And so I tried to order them in a way that was thoughtful. So stacking procedures all in a row or warning patients more clearly in advance about possible side effects on medications. I just had that sort of in the back of my head at all times when I was offering an intervention to someone. And then I think folks who are coming in with medical history or history of disability, I do feel like they come with a strong commitment to patient autonomy. One of the examples from the poem is the section where I am talking or walking past this patient in the ICU. This was a patient I saw as a medical student who had been diagnosed with leukemia. He was an older gentleman and he had started chemotherapy and he was very ill. And he didn't really understand what the chemo was going to entail. And I remember talking to him at one point and he said, "This is not what I wanted. Like, I didn't think that this is how it was going to go." And as a med student, to be able to understand why you would decline medical treatment at a certain point, rather than coming into the medical field with a strong sense of like, I'm going to save these people, I'm going to care, I'm going to cure everyone. That's been really helpful for me. And obviously I have a strong interest in palliative care because I think of that background that I have, but it allowed me to, I think, really understand more why patients were declining treatment or were not necessarily executing the plan that had been put forth by the physician or the care team. Also very interesting to me was challenges that I faced with this background. So as noted in the scene with this, the sim with the mannequin that's having the seizure and then codes and the director's like, "Your patient's dead." And this is, third week of medical school or what have you. That was very difficult for me. It raised a lot of anxiety. And throughout the whole rest of the year, I really struggled to like even go into the sim lab. And I don't think I understood why that was until I worked on these poems. But I do think that there can be triggers if you have medical trauma moving back into a medical space, and you might not always know, exactly what's going to come up for you. There's also a strong fear that I experienced of my illness prohibiting my ability to carry out clinical duties. Sometimes that fear was actualized, sometimes it was not. But I remember, for example, in a long surgical procedure where you're supposed to be standing for 10 hours, like not wanting to ask to use the bathroom, but knowing that I was going to have to do that, that caused a lot of stress. Even if I was feeling well, I carried that with me. There's also the isolation that I think is a challenge for folks when there's this false dichotomy of patient versus physician. So, being on rounds, for example, and a physician saying, "Well, if you're healthy like you or I, compared to, this patient over here, I think it's usually pretty safe to assume that most medical students are fairly healthy, but there are examples where that's not the case. And that kind of language was really difficult for me. I didn't really know what to do with that. And then most interesting to me is this idea of, if you have patient experience coming into medicine, how do you make sure you're not over-identifying with a patient role? How do you make sure you're not inappropriately generalizing your experiences to everyone else's experience that you come across? And then siding with the patient and maybe being like combative towards the medical team, feeling like your patient is not getting the care that they deserve. How do you walk that line? And then how do you identify with the physician role when you've been a patient for so long? How do you like step into that authority? Because we all want our physicians to at least seem like they know what they're doing. In the same way, we don't want to watch a magic show where someone is like bumbling with their hat and like the rabbits hopping around on the ground. Like, we don't want to see all of that stuff. We just want to see the result of all the practice. And so stepping into that authority, I think, is sometimes difficult if you have history of illness and you're used to being the patient in the hospital setting. So lastly, I just wanted to allow some room for my own wish list for medical schools. How can programs recruit and support students with history of illness? This is really specific for medical schools. I think residency is a whole other bag, and unfortunately is actually way more complicated, at least my experience was, but hopefully it's generalizable to other medical settings as well. So what I would love to see is medical schools use existing diversity recruitment structures, which have been vastly expanded over the past 5 to 10 years, which is wonderful, to include enrollment of students with history of serious medical issues and or disability. I think a lot of schools assume that if you have illness or disability history that you will disclose in your personal statement. And sometimes you might be forced to do so because you have like a gap in time where you took time off from college, or you had a less than stellar grade related to a hospitalization. But I do think it would be helpful to encourage and frame disclosure as a positive addition to an application. I put some language there that seemed neutral to me, at least, basically inviting people to self-disclose and that it's going to be a positive part of their application. I think that formation of student support groups would be incredibly helpful. I didn't meet other residents on purpose who had medical issues until COVID, at which time we were all kind of banding together because there was not enough PPE, and there are residents who, like me, are immunodeficient. There was a resident who had cystic fibrosis and didn't have access to like consistent N95s. So it was a very stressful time for that patient and provider population. But if that series of connections had happened much earlier in medical school, I think that would have been really wonderful. And then if there are faculty who are willing to step up and serve in a mentor role, I think that their time should be protected to do so. I think logistics in medical school are a nightmare for students who have illness background. So how do I request medical leave? How do I do that on my non-clinical and clinical rotations when you're rotating through with different, heads of your rotation every week? How do you get and request enforcement of appropriate accommodations, particularly when there are rotations that have high physical and psychological demands? If I have history of a seizure disorder and I can't work 7 nights in a row, how do I make sure that that's communicated to the right people? I don't know exactly what this would look like, but holding space for students who may struggle with witnessing particular medical experiences based on their personal history. So if there's a mentor-mentee relationship, being able to check in with students about that throughout their training. And then this is really important to me, which I know is not always possible, but it's very essential that students do not receive supervision from faculty they see for medical or psychiatric care, and that they should not be placed on a ward or clinic where they have received treatment, if at all possible. There was a really tragic situation at my med school where one of the students in our class had a son who passed away in our pediatric ICU, and the program was really wonderful about clearly not placing him on the pediatric ICU for his pediatric training, being very thoughtful around that. And I would love to see the same happen for students who have had severe medical illness or treatment at the facility where they're training. Obviously, that requires some amount of finagling and disclosure on the part of the student. So it's definitely requires an open dialogue, but I think it could be very beneficial. And then finally, medical insurance offered through the school, is it adequate for all your students? That's like the big cherry on top of the sundae that I have just described. So I wanted to leave time to chat. I listed a couple of resources here, my book being the first one. It came out again this month. I have copies to sell here if anyone wants to pick up one. I'd love to sign it. And then a couple of articles that I think are complementary to this talk. And then I just wanted to highlight the Stanford Medicine Alliance for Disability Inclusion and Equity. They're doing some really cool stuff around a lot of the themes that I just described. And so they're a wonderful resource for students. If you want to chat more about any of these things, but you don't feel comfortable talking to me now or via the chat, please feel free to message me through my website, and I'd love to talk more. Thank you. Should I move? Okay.
Okay. Thank you very much for that excellent presentation. There was so much packed in there, and so it was fantastic. We wanted to have kind of an informal discussion, and I'll be monitoring the chat as well. But I wanted to start off asking you kind of a broad question, which is, how did you come to poetry as your medium of choice? And specifically, how did this book come about? When did you first start writing the poems? And when did you kind of know that these poems were going to shape up into a manuscript?
Yeah, I think so. My parents were both writers in different capacities. And so I think I just did the only other mode of writing that they weren't doing as like my form of rebellion, which is a little bit silly, but I liked the intensity of poems. I liked the challenge of the form. So there are a lot of poems in the book that I didn't read that are in like more strict forms, like villanelles or sonnets and that kind of thing. I think it's a fun challenge. And I honestly have a really short attention span. And so poems just sort of called to me for that reason. Most of the poems in the book were written during my MFA, which I was here, I think 2011 to 2013. And then the long poem was started here, but then I hadn't done medical school yet. So I hadn't written the second half. So the second half of the book was, or the second half of the long poem, which is the magic poems, the cutting the woman in half and the escape poems that I read from, those I finished in mid-residency. So I took some time to kind of process that. And then there were a couple poems, like there's a poem about anatomy lab that was written later, obviously, but I would say the general core was written during my MFA. When you're in an MFA, you're writing towards a book. Whether or not that product is actually going to be a good book is another question. I think my general skeleton was sort of there, but I needed a lot more fleshing out. And so I'm really glad, honestly, that I didn't have time to try to publish it sooner, because I think having that space allowed me to kind of fill out the book a little bit more and to eventually braid that long poem through, which was a suggestion of I stole one of my husband's teachers to look at the book. And she had like laid out all of the poems at this coffee shop on this big table, because nobody was in the coffee shop, thankfully. And she was kind of like shifting it around, and she suggested more of like a chaotic organization of all the magic poems being like mixed together. And I was like, well, that's a little much for me. So I organized it by the magic tricks, but I did weave it throughout rather than have it in the center of the book, which was how it originally was.
Okay.
Yeah, that was a lot. Sorry.
No, that was great. It was a big question. Could you talk about, you kind of discussed being on both ends of the stethoscope, and it's clear how medicine from these different perspectives and experiences that you've had informs your poetry. But could you talk about how, if at all, you use your poetry to inform your practice of medicine?
Yeah, I'm really glad I did my MFA first, because I think my attention span had yet to be more destroyed by my medical training. And also it gave me like a really interesting perspective once I started into the field. So I would say a couple of things. One is that I really came to psychiatry through writing. I did an independent study with Marcia Childress, who's here, and we read Kay Jamison, we read a lot of other folks, and I was like, wow, this is amazing. That interest in narrative was just like really captivating to me. So that was sort of my entree into psychiatry, and then realizing that a lot of these physician writers who I knew were psychiatrists. I was like, this is a weird pattern, like what's going on here? And so once I got into medical school and knew I wanted to do psychiatry, I would say that it affects my practice both in the way I write notes. I'm very particular about how I write notes. People will send me like drafts of their notes thinking that they're being helpful for like an admission that's coming later, and I just have to start over. I think being a writer and then writing notes in an EMR is like an interesting conundrum to talk about at a different time, but I would say it affects my note writing style, but also really informs my interest in like psychodynamic therapy. So I don't do that in my current role as a consult psychiatrist, but I do hope to do that more in the future. I think listening to patients and hearing like rhymes between different themes and different imagery that patients are bringing up, that's like the core of that kind of listening. And I think my background in poetry really helped me hone that a little bit more.
That really resonates with me. I always talk about, kind of the recognition of language and kind of the playfulness of language, and having an ear for picking out the poetic way that many people naturally speak without labeling it as such is just such a cool feature of being a poet who's also a physician.
Yeah, I definitely pay very close attention to how people phrase things more than sometimes more than is necessary, but I definitely have an ear for that. And I feel like I will often like quote patients directly more than other people, because I'm just like, well, what they said is just so, it encapsulates everything, you know? So to use their language seems important sometimes.
Totally agree.
Yeah.
What is your writing practice like now, and kind of how do you balance that with your medical practice?
Oh, it's terrible. I keep doing this thing where I'm like, well, when X, Y, or Z happens, then I'll get back to like my writing stuff. I have tried to tweak my schedule a little bit, so I have longer hours, but then more days off. And I'm hoping once the book tour kind of settles down, I can get back into a rhythm. But I would say generally, I am not good at like sitting down with my like matcha latte and my like relaxing music in my special area and writing. I much more like to write when I'm not supposed to be writing. And so I have to like sneak in the hours. And so it's hard for me to have like committed practice. I more just do that terrible thing where you wait for inspiration to hit you, which I think is more of a poet thing, or I like to think of it as more of a poet thing. I think if you write fiction, you might have to be a little bit more disciplined just because you're having to produce so much more text. But yeah, I'm still figuring all of that out. Luckily, I'm very early in my medical career, so I have some time.
Yeah, I totally agree. And it makes me think of another question about kind of the writing process, because you mentioned that's sort of a poet thing that I also experience. And I'm curious if in writing this book and just other poems too, if you approach the poem by saying, okay, I remember this thing that happened or the specific memory, and I'm going to write a poem about it, or if you start from a more abstract place and then the memory or the content sort of surfaces out of that.
That's a really good question. It's hard retrospectively to always pinpoint, but I do feel like most of the time my starting points are either form. So I'm like, I'm going to write a villanelle, like what would be interesting to put in this particular form. So for example, I have a poem in the book called Hospital Through a Kaleidoscope. And a kaleidoscope is like if a telescope and a kaleidoscope had a baby. So you're kind of like refracting what you see when you look through it. And like that is how a villanelle works, right? It has these repeating lines that get changed and refracted. So that was like a pairing of form and content that was interesting to me. Most of the time, though, it's just a snippet of language or an image that starts it out. Particularly now, trying to navigate like things that patients say, wanting to remain HIPAA compliant, but also like, oh my gosh, that's a poem. I need to write about this. So I think that that's a balance to walk for sure.
Please feel free to chime in with questions for folks online or in person, but we can keep talking too. Yes, Marcia.
Yeah, I have a, oh, thank you. I love this book. Thank you. It's really wonderful. And I also love the extended metaphors that you used, all the magic tricks. And I think the ways in which not only directly, but also indirectly, the ways that you suggest and invite us to think about illness and medicine as in the realm of the magical and what we do with that. But I'm also intrigued in some of the poems that you read, and in reading the book, and in looking at your slides with the visual interest of the intersecting lines. Would you talk a little bit more about the prevalence of origami practice in the book, in the poems? I noticed particularly at the end of that very awkward conversation with the doctor that you have the last word with making some origami cranes.
That's a great pickup. Yeah, I think I associate doing origami with being sick. It seems like something, I mean, that's the only time I ever did it, was like when you were in a hospital setting or a clinic and you're looking for something to do and you're a kid, people, the child therapist will come around and do like arts and crafts. And that was one of the things that was sort of brought up. I have never done origami since that time. I have no interest in origami. I love to look at it, but I have like zero patience for it. But it felt like an interesting metaphor, both because of its relation to the dove, because we were often doing birds. And then I think I was also thinking about the, what is the legend about like the paper cranes when you're sick? You know what I'm talking about? It's like if you fold a certain number of paper cranes, it will keep you from illness. So this kind of like hope with turning something flat and quite boring into this like beautiful object that was very appealing to me, because I felt like that was sort of what I was trying to do with writing these poems. Like, how can I make something meaningful of this generally bad thing that happened? And I think I made meaning of it through both writing the book, but also through my practice in medicine. And to be able to do both of those has been really special way of like transforming those experiences into something really wonderful.
I wondered if you could talk a little bit more about the disability advocacy piece and medical education. So I loved your wish list, and I'm curious if you're aware of the extent to which some medical centers are starting to do some of the things that you propose, or if there are other reforms that you've seen in different medical settings that are starting to make medicine more hospitable to people with disabilities and history of chronic illness.
I definitely think the disclosure piece is being talked about a lot. I'm sort of out of the academic world currently. I work at a VA hospital that's not attached to a big medical center, but I know from friends' experiences that people are speaking more about disclosure and how to disclose. And there was even a panel that I was a part of at Yale while I was still a resident for medical students about disclosure, like whether or not to do it and how to do it most effectively towards whatever aim you had in the disclosure. In one of the articles I linked, they're talking about the increase in purported students with medical illness, history, and disability. And I wasn't totally clear if that was based on just more people disclosing that they had it, because they're everywhere. Like one of my great friends in medical school had a very serious medical issue that he didn't tell me about until several years into our relationship, which was really shocking to me and really made me realize, he had always been so empathic in our relationship with those issues that I had. And I just would love to hear more people speak about it. And so I figure I'll just throw my name out there and see if anyone else joins me. And I think more and more people are doing it.
Yeah, I think that, in kind of the popular culture of medicine, or sort of the gray literature, I guess, I'm starting to see more people talking about mental illness specifically and disclosing mental illness in medicine. I think probably in part because medicine is such a high stress field, and we do have such a higher risk compared to the baseline population. But I would like to see more of those stories as well, about not to separate the mental and the physical and the false dichotomy, but other types of illness as well, and other types of histories of chronic disease
and disability too.
Mm-hmm.
I think that would be wonderful to see. It's hard to know why certain people feel comfortable disclosing versus not. I think it has a lot to do with like the age of illness, the type of illness, what kind of medicine you want to go into. Like if I'm going to go into a hyper competitive field that's surgical, I probably want to guard that secret. Like if I'm worried about matching. Whereas I was lucky in psychiatry, I know it's much more competitive now. Thank goodness I don't have to match these days. But It was sort of like, if you're interested in psychiatry and you're a pretty good student, you're going to match into psychiatry. And so it felt a lot less risky for me to do a large amount of disclosure throughout like the residency process. But I was in a privileged position, obviously being a white person going into a field that is not as competitive. And so I know that there's a lot of variables at play for people. So it's important to consider, I think, all that as well.
That's a great point. There's so much about the microcultures of different specialties that can definitely impact the experience a trainee has. And like you said, the comfort with disclosing something like that.
And I know a friend of mine who does have a similar background to me, who was encouraged by some mentor that she had who knew her very closely that maybe she shouldn't go into a surgical field. Ultimately, I think she was really grateful for that point of suggestion, because the person was really trying to project out this life that she was imagining and wanting to protect her health at the same time. And, you know, you never want to tell someone, obviously, you can't do X, Y, or Z field. But I think in that case, the match was, it was going to be a much smoother, more supportive environment for them to be in a different field at that point in time.
Yeah. Fantastic. Any other questions? Go ahead, Justin.
Well, thank you so much. Again, there's so many different ways we could continue to take the conversation, but I was struck. I kept thinking about another psychiatrist writer, but in this case, an anthropologist, Arthur Kleineman, who has taken a really interesting pathway in his own writing in the last decade or so as a caregiver. And he wrote this essay in New England Journal almost a decade ago now called From Illness as Experience to Caregiving. No, Illness as Culture to Caregiving as Moral Experience. And I was thinking about that because I was struck as in terms of the arc of your presentation today, how we ended up in ethics, how we ended up with here are some things that we need to do as we think about this through art and through literature. And one of the things that he talks about in that essay is he basically ends up saying we all need to be caregivers, all of us who go into any kind of clinical field. We all need to have that experience. And I wonder if you could just comment on how can we all make sure that we walk around in the shoes of illness as clinicians better as we educate ourselves, as we practice, so that we make sure that we are not, to draw from a line of one of your poems, that we are not just creating a list of two stapled pages of negation, and thinking about those positive steps as moral and ethical experience.
That was a beautifully worded question. Thank you. Yeah, I mean, obviously, I don't mean to suggest like everyone needs to have an illness experience to come into medicine, but we're all going to have an illness experience eventually, right? And so if you aren't coming into medicine with like a close family member with illness, or having a caregiver sort of role or a personal history, I just think illness narratives in any form, there's comic books, there's poems, there's tons of memoirs now, like a whole book. I have bookshelves of memoirs of illness narratives, which I think is wonderful. There's been like an explosion in that category of memoir. I think reading those, even for me too, like I don't have a strong history of psychiatric illness, but all my patients do. So how do I inhabit their world for a bit of time to really get a better sense of what they need and what they're experiencing? Obviously, I can listen to their stories, but there's also work that you can put in on your own time. And those illness narratives have been really, really helpful for me. And I've actually done like lectures for residents on different psychiatric illness narratives and different categories of illness that I think would be helpful to read about. Particularly, it's really hard to understand the experience of psychosis. So how do we do that? Well, there are some books talking about the history of psychosis and their own personal experience. And I just want those to be utilized more as resources. I think they can be really helpful.
To follow up on Justin's comment and your comments and also your wish list for medical schools. Years ago, we had Arthur Kleinman here as a speaker, and he did a small seminar with us as well, in which he came with something of a wish list. And that was that if he were to redesign a medical school, he would make much of the first year custodial caregiving, so that everyone was hands-on caring for patients and brought that experience into their education, not just relying on the fact that maybe there was someone in the home or in volunteer work that students had worked with, but really making it an integral part that they had to connect up with their professional identity.
Yeah, I think that one thing that I see as a consult psychiatrist that is very befuddling to me is providers who don't like even know the name of the nurses on the floor that they cover, and they don't know the CNAs, and they don't know any of the environmental staff. And these are people we see every day. I mean, for me, part of my job is knowing who these people are, because a lot of the consults we get are actually staff anxiety related to patient care. But an appreciation for the other caregiving roles of medicine, particularly nursing and CNA work in an inpatient setting, I think is really underappreciated. I think you do see a difference with folks who have had that history and that background of caregiving when they come into the medical setting, of really having a lot of respect and being able to engage with those folks in a meaningful way.
I don't see any questions in the chat at this time, and we just have a couple more minutes. So unless there are further questions, I think we could break here maybe, and there are books outside for anyone that wants to purchase a copy or copies. We can do some signing if you have.
Sounds great. Yeah.
Okay.
Thank
Great.
you all so much.
Thank you all for joining us.